Fourmalier, who is also a BPH expert, and Holep Proctor, having published also many papers and proctored many surgeons to start performing Rhizome therapy. Thank you both for joining us.
Thank you, Joseph. Good afternoon to all the attendees.
Our disclaimer in the beginning. And also we encourage you to log in and register to Educare, where you can access a lot of videos, a lot of educational tools that you can use in your practice. Our agenda for today, first of all, we'll speak about the mechanism of action of water vapor therapy. Then we will present some real-world papers and speak for sure about the success parameters based for sure on the evidence. And at the end, we will, if we have time, we'll show some videos about the post-operative results. And at the end, we will allocate 10 minutes for your questions. So, Mark, the floor is yours.
Yes, thank you very much, Joseph, and hello, everyone. I'm very glad to be here to talk to you about the Rhizome system. I would like to thank Joseph and Boston for this webinar. Okay, we're going to start with the mechanism. Next, please. Next, please. Okay, as you know, Rhizome is a very different way of applying thermal energy to treat LUTS, secondary to BPH. And we have the unique in three ways: heat source, heat transfer, and content within the prostate anatomy. Next, please. Okay, the Rhizome system includes a generator and a handpiece. And on the screen on the right side, you can see the water vapor delivery to the transition zone. And what we know is that each injection, each punction lasts 9 seconds, and we're going to treat 1.7 cubic centimeters. And you can see that the vapor don't going through the capsule, and this is why we don't have any collateral damage. Next one, please. So what is a very unique heat source is that we have 540 calories of stored thermal energy, and it's released during the fat change from water vapor to water. And as we know for many years, that beyond 70 degrees Celsius, we have instant cell deaths. Next, please. And during the Rhizome treatment, just before. Yes, thank you. So during the Rhizome system, you have the difference between the water vapor, more than 100 degrees Celsius, and the prostate tissue, 37 degrees. And we have, we do have a temperature increase at 70 degrees, and this is why we have the cell deaths instantly. Next one, please. Thank you. What is very important, very original, and that's the difference with the old one, if you remember the tuna system, that was a conductive radiofrequency thermal energy. If we have convective radiofrequency thermal energy, and that's the main physical effects. It's that you inject 0.42 milliliters of vapor dispersed through interstices of the prostate tissue and just to the capsule. And this is why you don't have any collateral damage, and especially on the neurovascular bundles. And on the right side, you can see the conductive thermal energy. And if you remember, it's a heat transfer cell to cell, time after time. And there is no, the limits, you can go through the boundaries. Next one, please. Yes, thank you. And what is very interesting, and I'm repeat, but that its water vapor cannot penetrate the zonal boundaries, and therefore stays with the zone it's injected. It is why it's very important to don't overtreat, and you should treat only what is obstructive on the prostate adenoma. Next one, please.
Thank you, Mark. I think now we're moving to the next topic for today, which is published real-world data with Luca.
Thank you, Joseph. What I would like to do is try to discuss with you and all the attendees if what we learn from the first and unique randomized clinical trial we had about Resume is similar in the reality. When you look at the literature, normally, for example, looking for drugs or new technologies, all the companies needed to publish first a pilot study, randomized clinical trial. But when you test, when you try to have the same results in the clinical practice, sometimes you could be disappointed by these results. So this is the topic I would like to share with you. Please, next slide. What we see, what we learned in the literature. In the literature, we have a lot of publication, and the randomized clinical trial study that is the best we can have as evidence was done on patient had a prostate volume ranging from 30 to 80. With certain IPSS score, certain Qmax, certain age, never operated, not even treated with any drugs, not taking anticoagulants or antiplatelets in their life. So in real life, unfortunately, or even fortunately, we have a lot of different patient scenarios. We have patients with a lot of drugs, with huge prostates, with impaired bladder function, with catheter. So the question we had since the beginning of a personal experience was, can I treat this kind of patient? Can I mirror the same results we learned in randomized clinical trial? Next slide, please. The randomized clinical trials and the 5 years results of the McVally study demonstrated a very good safety profile, a very good effective treatment with a good reduction in terms of... Next slide, Joseph, if you can. Thank you very much. Again, the new one. The next, please. We demonstrate, next one, please. We had a good results in terms of IPSS reduction and increase in Qmax, increase in QOL, in quality of life, as also in BPH index. This means that from the treatment to the first 3 months, we are able to halve the symptom score. We can increase the flow rate of more than 50%. And this is quite the same in terms of quality of life score and BPH indexes. Next slide, please. So this study was so convincing that Resume is effective, and especially for what is retreatment rate is concerned, we know that from the first to the second, the third, and until the 5th year after the treatment, we have a 4.4% of patients reoperated, and 10% of patients that are retreated with drugs. In real life, we are able to duplicate these results. We didn't know at the beginning, so my perspective was to look into the literature and understand better what we can have, what we had. So you can skip, Joseph, yes. The literature is very rich. Skip, no problem. We have a lot of paper concerning the expanding indication. We have a paper on failed patient with catheter, patient with huge prostate. You can go. At the end of the history, we was curious about the possibility to understand what were the predictive factor after the Resume. We had the need to understand if the catheter, patient catheterized, could be treated or not. We dedicated part of our activity from clinical point of view and also scientific in order to resolve this question. And we arrived to have a good database of Resume with a good 2 years and more of follow-up, and we published 2 original papers I would like to show you. Next slide, please. You can also skip this one. This was a first attempt to enlarge the indications. So we collected, you can skip. We had more than 400 patients, and we divided this cohort in 2 groups of patients. A group mirroring the criteria of randomized clinical trial and a group of unselected patients, okay? So we have the perfect patients and the perfect and the unperfect patients, patient of real life, the common patient arriving in our hospital. Next slide. Here we have a table that showed all the differences between these 2 groups, and there are a lot of significant differences because we had in a group of perfect patient, group A, a lot of patient in good health. On the other part, we have in the group B, patient with anticoagulants, catheter, bladder failure, and so on. Next slide, please. The treatment schema was quite the same. The number of injections and especially the injection density at here, 4 row, showed that we treated the patient in the same way. Of course, the patient in the group B has an exceeding volume prostate, so needed more treatment. But the catheterization time was overall quite the same, as well as the retreatment rate. So next slide, please. If you look at the functional outcomes, in blue, you can see the group A, in B, the group of unselected patient. You can skip, Joseph, please. You can see that as far as the Qmax is concerned, the PVR, the IPSS and IPSS quality of life are quite the same without statistical differences. This means that in these 2 groups, the postoperative success is achievable in the same way. This was the first study comparing patients that satisfied all the randomized clinical trial inclusion criteria versus unselected patients. For us, it was a great success because finally we had the opportunity to expand the indication and use this energy to treat different kinds of prostatitis. Next slide. In order to understand if what we expect in terms of real life studies, we can say that yes, in the real life, we have more or less the same results of the randomized clinical trial. The problem is that in the randomized clinical trial, some topics like urodynamics, the presence of catheters, large glands, frail patients are not even studied. So in the real life, on the contrary, we have a lot of information about this kind of patient. Next slide, please. As far as urodynamics is concerned, we conducted an initial study on only 17 patients treated by Resume that received the urodynamics before and 3 months after Resume. This is a small group, we know, but it's difficult to convince someone to repeat the urodynamics just to understand if his bladder has increased or not his function. Next slide, please. And finally, we demonstrated that in terms of parameters, but also in terms of Schaffer class change, we have significant difference between before and after the Resume treatment. Next slide, please, because there is a graph very informative. Here you can see, as you can see, not only IPSS, Qmax, the typical index, but also the change of bladder obstruction index and the Schaffer grade, the Schaffer class reduction before and after the treatment, so during the follow-up. Next slide, please. So the real life, again, enriched all of us as urologists because it's able to reduce obstruction, improve symptoms, and limits the post-voidal residual. Next slide, please. What is about the catheter? The catheter seems in the beginning we are scared about this because we consider the reduction of prostate volume not so brilliant. But this is not true. It is possible to remove the catheter after a resume. Yes, and notice my reply. The reply from the literature is that overall, more than 85 to 90% of patients with catheter was able to remove their catheter. So, wow, it is really working and it's possible to remove the catheter. Of course, some certain percentage will still under alpha blockers or drugs, 10 to 15% still under clean intermittent catheterization or even indwelling catheter should be recognized. But we have an important number of patients. What about the big prostates exceeding 80 grams? We had a study already published in European Urology Open Science some years ago. This was called the XL resume study. So the resume for XL prostate, and the prostate in that study has a median prostate volume of 93 cubic centimeters. So next slide, please. A lot of patients were treated, and during the time, their results was stable. If we define in such a way the response rate as defined here, you can see how is defined. We can say that from 6 weeks after the treatment to 12 months, to 1 year, the percentage of patients that have a positive response defined, as you can see here, is stable. So if we perform a resume in a big prostate, this patient will have a good results at least for 1 year. This is the main message. Next slide, please. Especially when we have a patient that desire a minimal invasive approach for treating their prostate and patient who desire, for example, preservation of ejaculation. Next slide, please.
Thank you, Luca. So this is not, as you have said before, this is not the main indication, but it's part of the indication.
Okay. Yes, this is not a good indication. Mm-hmm. What we can say about the fragile patient? Again, we have this great study, great cohort. We split into groups, as I've done before. Please skip. Go to the next slide, Joseph, s'il te plaît. Et voici, et encore. So we have here, again, a group with different age, different prostate volume, difference in terms of sexual function, of course, and especially as a score. These patients were completely different. And we have patient with catheter. We treated, next slide, we treated this patient. Each center performed their treatment following their protocols. At the end of the history, we treated this patient in the group A1 and in group 2, so the group 2 is fragile, I remember. The number of treatment was quite the same. And what we can say in these two groups that no difference were found in terms of postoperative complication in general. And only a few patients required hospitalization for blood washing, and the differences between postoperative course was similar. As far as the reintervention is concerned, there is no differences about reintervention. So we can treat also patients aged more than 78 with a lot of comorbidity. This technique seemed to us that should be proposed particularly to people having multiple comorbidities and subsequent augmented anesthesiological risks. Why? Because we can perform this under mild sedation or even local anesthesia. Okay? So, concluding my first presentation, next slide, please. We can say that in real life, we resolved some issues that in randomized clinical trial left unresolved. And so for that, we are very happy. This is the reason why I personally consider, next slide, please. We consider the resume a very good opportunity for old men, aged or young. And personally, I consider resume one of the best friends of the men, and in order to treat their prostate symptom, maintaining sexual function and maintaining antegrade ejaculation. Thank you very much for the instance.
Thank you. Thank you, Luca. Thank you so much. Now we will move back to Dr. Fournier to speak more about the success factors in terms of patient selection, patient counseling, all the other parameters than the surgical technique. So, Mark, again, the floor is yours.
Mark, could you please activate your microphone?
You hear me?
Yeah.
It's okay?
You can go.
It's okay?
Perfect.
It is of course necessary to clearly indicate the type of treatment. It's treatment intended to relieve symptom, obstruction, and reduce prostate tissue. We will prefer to begin with prostate between 13 and 80 grams, especially during the learning curve. And we got prostate hyperplasia of the central zone with or without median lobe, because don't forget that's one of the good job of the rhythm system, it's to treat the median lobe. And the profile, the patient profile, it's patient not wanting to take medication anymore, not enough bothered to choose surgery, and the contraindication is urinary infection, urinary implant, and penile prosthesis regarding the risk of thermal damage. Next one, please. Please. Yes, okay. Okay, the preoperative evaluation, very important to have an ultrasound evaluation, and it's always the same case of endoscopic surgery for prostate. It's very important to know the volume and the presence of absence of median lobe to have a three-dimensional vision. Regarding anticoagulants and antiplatelet, you can keep aspirin, and it's possible under clopidogrel. There is a risk of hematuria, but it's not a very high level of risk. The urinary analysis must be negative, indeed. And about anesthesia consultation, it's a very interesting subject, but it's not the subject of the day. But you can make it under sedation plus hypnosis, general anesthesia of prostatic block. Next, please. Okay. So we will illustrate our points with this excellent paper from Luca Scandalo's team. It's a study about 262 patients, mean age 65, prostate volume 59, with median lobe for 65% of patients, urinary retention with bladder catheter 14%. Next, please. Okay, for the results, we have the median number of injections 7, duration of procedure 11 minutes, median injection density 9, median postoperative catheterization time 7 days, 6 to 10. Next, please. Okay, and what's the definition of the success urinary outcome? The first one is the reduction more than 50% of in IPSS index or score less than 7. Next, please. And you can see in this paper that the result is 70%, so it's excellent. And for the improvement in peak flow, more than 50 or more than 15 milliliters per second, 70%. One of the definition of the success is more than 1 point improvement in the quality of life questionnaire. We have here 92, it's done. And it's very important to have perioperative complication, very less level, very low level, and to avoid transfusion, Clavian more than 3 on postoperative incontinence, and that's the case because we have 97%. Next one, please. And what's the definition of the success of sexual outcome? The first one is the postoperative antegrade ejaculation. As you know, it's a question of all patients, or no variation in ejaculatory function, and it's done. We have 78% of success, increase of stability or max 1 class reduction in IIA5 scores, and it's done because we have 91.7%. It's excellent. Next one, please. So the question was, what was the factor, the predictive factors of success of feathers? And we can see next one. What is very interesting is this paper. It's that you can see that Qmax, IPSS, PVR, age, prostate volume, presence or absence of catheter are not predictors of success. So we can achieve a success independently from these factors. And this is what is very interesting with this kind of minimum invasive treatment. Next one, please. Okay, and now what about failures? Because we are talking about success, but there is also failures. That's life. And if, this very interesting paper from neurology 2 years ago by Vapour, that was a retrospective study, 289 patients, and you can see that the rate level of failures is 12%. And what is very interesting is that the only independent risk factor was the baseline PVR, and particularly more than 200 milliliters. And in parallel, we can see that the duration of bladder catheter is more than 10 days for patients with chronic urinary retention. Next one. In the same way, last year, we had a very interesting paper from Brussels about 200 patients, and we can see that the rate level was 10.6% of failures after 7 days of catheterization. And you can see also that the only predictive factor was the PVR preoperative, and here the cutoff was especially 180 milliliters. Next, please. So, one more interesting question is the number of injection. That is very interesting, and we can have here the retrospective study. In the study, we have 4 groups, 1, 2, 3, or 4 injections per lobe. It's about 179 patients. And you can see that there isn't any significant difference in terms of IPSS, quality of life, PVR, and IIF5. But for each additional injection, we have multiplied level, and for the macroscopic hematuria, it's multiplied by 4. For the burns, urethra burns, of penile burns, more than 2.6, pain 2.2, and dysuria by 3. So one of the very important message today is don't overtreat. It's very important to avoid any side effects for your patients on postoperative treatment. And you should only treat what is obstructive. It's very important. Next one, please. So, and finally, and as always, the key to success is to communicate with our patient. And the communication is so important, you know that, to understand the symptoms, to make the right diagnosis, avoiding versus storage symptoms, listen to the complaints, concern, and expectation, and especially for sexual function, and take time to explain all options, all the minimal invasive treatments, the classic treatments, medication, surgery, and so and so. And it's important for the patient to understand the technology, the data, the outcomes, the perioperative journey, and especially the side effects and the sexual side effects. You can talk about sexual function. It's important to talk about ejaculation because you can see in the literature it's not zero retrograde ejaculation. There is a level of retrograde ejaculation or anejaculation. It's possible. So you must say that to your patient, and you must write in your paper. It's very important on your laptop, on PC, for example, but it's very important. Next one, please.
So now it's time to talk about the post-operative results and the patient follow-up.
Okay. Yes, I'll begin, no problem. For the post-operative follow-up, you'll see that it's a very classic and the post-operative consideration. First of all, for example, in France, for the reimbursement, we have the possibility to have outpatient hospitalization, 1 day surgery. It's difficult to have a classic hospitalization. For the bladder catheter, it will be stay 5 to 7 days, but until 21 days for chronic urinary retention, for example. It's an outpatient procedure. It's very important. And we can keep alpha blockers and non-steroidal anti-inflammatory 7 to 21 days. It's up to you. And the follow-up is very classical, 3, 6, and 12 months. Qmax, PVR, PSA, IPSS, quality of life, and the follow-up for sexual function, MHSQ on IF5. Next one, please. Okay, we have here very interesting radiological images that was on the MRI study that was just before pilot study in the United States. You can see the images 1 week post-procedure and 3 months post-procedure. And it's very interesting to see that. We know that there isn't any relationship between oh, sorry. Yes. Okay, next one, please. Okay, what is also very interesting in this MRI study is the volume reduction. You can see here on the transition zone, it's 48. The prostate, the global volume of prostates, it's 40%, and the total lesions, each time you make an injection, it's 99 on the MRI study. Next one, please.
Okay, thank you, Mark. And this is to mention that this paper, as we said, says the prostate as 1 week compared to 3 months, right? It was not the pre-operative prostate volume, just to mention that could be a source of confusion.
Yes, absolutely. Okay, here we got a very interesting video, pre-treatment and 6 months later. You can see that the prostate of 52, 3 treatment on the right lobe, 4 treatment on the left lobe, 2 on the median lobe. And you can see 6 months later, there isn't any median lobe anymore. And it works very well. The patient was very happy about that. You can see the difference, and especially on the median lobe. The next one, it's a small prostate of 31 grams, 2 treatments on the right lobe, 2 treatments on the left lobe, and you can see there is a big gap on the posterior wall of the prostate. Next one, please.
Mark?
No, yeah, let's move. Thank you,
Mark?
Mark.
Yes.
I don't know if you can just stop a minute because I have 19 seconds videos. Joseph, do you have my video ready or I share by my screen?
No, I can share it. Just a second.
It's an incredible case just about the possibility to remove the third lobe. It's a patient with 2 centimeters of intraprostatic, intravesical protrusion of the median lobe that I treated, I think, 4 years ago. During his follow-up, you can launch the videos when you are ready, Joseph. And this patient had an history of regular follow-up. I've seen a small tumor in the bladder. I say, you don't need cystoscopy for the BPH. You need cystoscopy for the suspect of bladder cancer. Look, this is just a small clip done by the telephone. I'm doing a cystoscopy. Look at here, all the white zone of the complete ablation of the third lobe. You can criticize saying that on lateral lobe there is not too much effect, but I can assure you that the third lobe was huge, invading the bladder. Okay, then I confirmed the bladder cancer and then I treated this patient. But it's incredible how this patient is still stable because I'm doing regular cystoscopy every 6 months. And now we are around 9 to 12 months because it's the third year. But it's incredible how this third lobe was completely disappeared, reinforcing the concept that the vapor administered by rhizome system still into the capsule doesn't exceed, don't goes away, still in the prostate until a complete ablation of the root of the medial lobe, the central zone. So it was just to reinforce the concept because I found the video yesterday.
Thank you.
Yeah, absolutely agree, Luca. And I don't know for you, but I think it's very interesting to treat median lobe, but also bladder neck, because when you treat the bladder neck, you get a very good result on the outcomes. I think in one treatment, one injection in the bladder neck, it's enough, and it's very good results. It works very well.
Let's talk about the pre-treatment planning. I think flexible.
Yes. Of course, when we plan this kind of treatment, I think ultrasound is very important, is essential. I don't know if you like to still performing transrectal ultrasound. Personally, I quite abandoned, but I perform an ultrasound by suprapubic approach personally, as I prefer to perform also a flexible cystoscopy. This is just to exclude presence of stenosis stricture, but also to understand if there is the right median lobe, if we can treat the elevated central zone, if can we approach all the intravesical protrusion, because sometimes we have huge third lobes that cannot be treated by this. Until 2 centimeters of intravesical protrusion, I think what could be treated with success. Next slide, please. So when you prepare this patient, consider to do this minimal assessment. What is my tricks? What are my tricks? My tricks are, first, don't go wild. Don't approach the huge prostate since the beginning because you could be disappointed by the results. We are unable to manage this post-operative particular care period. So it's better to start, as Mark said, from 30 to 40 to 80 grams. We stay on the track. Then it is important, this is a personal suggestion, to record all the patient-reported outcomes in pre- and post-operative, because this is very important to demonstrate to the patient that you achieved a success. If the patient is waiting for extraordinary micturition and you would like to pee at 2 meters of distance, presume it's not good. But if you like to stop the medication, if you anticipate to an increase of 50% of their Qmax, you should have any time on your paper the preoperative and postoperative results. and also record the motivation. If the patient is unable to tolerate alpha blockers, it's so important you put this into your record. You say, Mr. John, who is not able to tolerate alpha blockers for hypotension. Okay, this is a good motivation for resume or even another treatment. But it's so important you have this in your paper. Otherwise, in the future, you can be also litigated and someone could discuss with you saying, oh, come on, you could do TURP. Yes, but Mr. John would like to spare his ejaculation, or his patient refusing hospitalization. I had a lot of patients during pandemic that they came to me just because they would like to skip hospitalization. This is so important. Next slide. The resume is simple. It's not stupid. Simple to do, but not stupid to understand. I will say this works like focal therapy, but it is a focal therapy distributed to all the adenoma. So my schema is fix a first consultation prior surgery. Avoid to assign the visit to someone inexperienced. Be ready to discuss to the patient different opportunity. And I will also suggest to review pre-existing record, do personal examination, and especially ultrasound should be done by yourself. If you are able to discuss with the patient, I think it's a very important you still open and quiet. You should try to listen the patient expectation and try to reply to all the questions of this patient. The patient of the resume are not a common patient, a patient that is demanding and is normally able to criticize even your position because normally are very well informed. Next slide, please. So please don't say this is like a TURP. This is not like TURP. This has a postoperative course that could be even worse in the first day. Could you change the slide, please, Joseph? This is important that the postoperative course should be anticipated and not refuse to. So my suggestion is also to spend time to understand, to ask yourself, is this patient a good candidate for resume? It's better to analyze once, 2 times the record you have and open a discussion with these patients about advantages and disadvantages. Some patients lives without problems with retroejaculation induced by silodosin or tamsulosin, so they are not disturbed by this effect, and they are good candidate of resume or not. This is up to them. It's not up to us. Okay, next slide, please, Joseph. So my position is to stay far from personal indication too much, but of course, if you have huge PVR, chronic retention, hydronephrosis, bladder stones, or whatever, it is important to say to the patient, come on, you need a maximal deobstruction, a fractional deobstruction would be too few for you. So this is the case of a good deobstruction, for example, for a HOLEP. So verify with the patient that he's able to understand and aware about the fact that resume could take time until the effect set in. Be aware that initial urination can be even worse in the first 2-3 weeks. The risk of postoperative urinary retention is around 10%, and the risk of infection and postoperative urination, burning urination, is around 20%. So inform your patient and go straight on your pathway. Next slide, please. You can also skip this slide because I've already explained my personal position. I can stop here, Joseph.
The next slide will be for Mark, I think. But also, so you can tell us maybe about your approach. So you select the patients first. This is very important in terms of success. And do you consider a specific publication when you select the patient, like regarding the PSA, regarding the median lobe? Do you restrict
Yes.
if the prostate anatomy is different, or if you have a specific, for example, anatomy, does it affect your decision when you want to treat a patient?
Yes, Joseph. I can't hear you. Could you repeat?
Do you take into consideration the median lobe when you decide to perform?
Okay. Yes. The presence of medial lobe is a good criteria for resume, especially if your third lobe is 1-2 centimeters of intravesical protrusion. And personally, I consider the medial lobe a good presence, so is a very good candidate. I prefer to do resume in patient with the medial lobe because I'm quite able to destroy all the medial lobe. We can achieve a complete disappearance of the third lobe, as I showed before, but probably what we see is a decrease of the mass of the bulging into the bladder. That means we are not more adenoma flopping into the channel, into the prostatic urethra. And this is a great success because the patient with the 3-lobe prostate has a good success if you remove only the third lobe because it's the obstructing part. If you look at long-term results of several studies, the selective third lobe ablation or photovaporization or resection or enucleation is sufficient to ensure good micturition and low reintervention rate. So no fear about third lobe at all.
There are limits as well when
the giant medial lobe are not indicated. I will say more than 3 centimeters of intravesical protrusion for me are not a good indication. 3 centimeters is enough. It's very good. A lot of prostate.
Okay. Thank you. So that's slide will be for Dr. Fournier. You can show us some of the treatments that didn't work actually, and if you can tell us how to avoid these complications. We cannot hear you, so you are on mute.
Yeah, that was a video of failure at 6, 1 year, and 2 years, and it's very important. On the left side, you can see a failure at 2 years, and it's very interesting to see because for the bladder neck, there isn't any problem, and you can see at the apex, you can see 2 gaps all around the apex. You can see very well. That was very interesting. That was a failure at 2 years. The next one in the middle, it's failure at 1 year. And you can see on the left side of the patient, there is a big gap. You can see that there is a big gap. And it's what Lucas said. It's until the capsule, you can see that. But for the bladder neck, that was obstructive on the right side. And the last one is very interesting. That is what we said, because you'll see that on the lateral lobe, there isn't any results, but there isn't any bladder neck anymore. And this is what we said, and that the same about median lobe and bladder neck obstruction. It works very well, as you can see. So there isn't any good results on the lateral lobes, but on the median lobe and the bladder neck, that was excellent. But that was failures. But this is what Lucas said. It's a minimal invasive therapy. It's not surgery. And for me, it's really against medication or between medication and surgery. Thank you very much.
Thank you. Thank you, Mark. Thank you, Luca. I don't see many questions.